For the crisis management series, I'm going to be going over what I think should happen with these two cases and how to effectively treat them. For case number one, it is a 45-year-old man. He has been married for 15 years and he has overcome his addiction with pornography, but also has suffered from major depressive disorder. He came home to find that his wife had left him and had been cheating on him for 2 years and took his children. And it has been a month since he has spoken to his children. He is unable to go to work. And he is expressing feelings of hopelessness, saying that he doesn't know if he can go on if he can't see his children. It is really important as a psych nurse practitioner to remember that to look at the risk factors for every patient. So some risk factors that for suicidal ideation and attempts, or even a completed suicide that this man is experiences that he is male. 80% of suicide attempts or completed suicides come from men. He is divorced or he is in the middle of divorce proceedings. So I would consider that another risk factor. He lives alone. He has even stated that he hasn't seen his children in a month. He is going through stressful life events, such as his wife leaving him and not seeing his children and going through the divorce proceedings. And he also has said that he has a plan to shoot himself. So he also has some psychiatric disorders. He has a history of major depressive disorder. He has a history of pornography addiction. And then he also is currently exhibiting alcohol abuse behaviors by the amounts of beer that he's drinking each night. He also is stating that he feels hopelessness when he says that he feels like he's never going to see his kids again. He has no will to go on. He can't go into work. They gave him time off, but he says that he finds himself just calling in all the time. And he also has anxiety about whether or not he's going to see his children. He keeps saying, he feels so stupid. How did he not know his wife was cheating on him for 2 years? So when we are assessing these patients, we also need to ask proper questions. A lot of times people worry that, if a provider asks them about their suicidal thoughts, that it's going to put the idea in their head. And that is simply not the case. Most times patients are very relieved and they are happy to talk about it with somebody that can help them. So what I would do as a provider is I would ask the patient if it was okay to call a family member. And I don't know if this patient would have a family member that we could call. It seems kind of like he's very alone, but if he did have a family member, I would call if he gave me permission and have that patient wait there, have the family member come in and interview the family member in front of the patient to kind of see what they think is going on with the patient. See if any of their behaviors, if they've noticed these changes, and also to kind of get somebody on board to help. It's important that this patient, we need to recognize that he had a plan, which is a major part. He's not just having thoughts of suicide, he is actually having thoughts with plan, and he's going to shoot himself. So we need to find out, does he have access to a gun? And if not, we need to find out how his plan is to get a gun. So I'm going to evaluate this patient. So he most likely does have access to lethal means. I am guessing he has poor social support because his wife and children are gone and he's feeling very alone. I don't know about other family members, but I'm going to guess that he has poor social support. I think that he does have some poor judgment at this point. I think that he is very much tunnel vision and feels so hopeless over what's been going on that his judgment is not well. He is having thoughts of suicidal ideations. So I'm going to say that he has poor judgment. And I don't believe that I could get him to sign a contract for safety and feel like he would follow that. I kind of feel like he's probably like a lone wolf right now at this point. And I wouldn't have anybody to help ensure his safety. So what I would do as a provider, after assessing him, I would make sure I don't leave him alone. And my goal would be to hospitalize him. Everywhere is a little bit different how they would do that. Um, where I live, we don't have a lot of inpatient units locally that will just take patients like that. I live in like a rural beach community. So what I have found in my clinicals, and if I work in this area, what will probably happen is we have one emergency room that takes psychiatric patients. And they have a psychiatric emergency department, and there they will do a psych eval, and they will evaluate them. And if they find that they are suicidal or have suicidal ideations, they will admit them to our hospital unit. So that is what I would do. Now, here's the thing: I can't leave him alone. And I don't know if he's going to go voluntarily or not. So if he doesn't go voluntarily, I would have to see if I could get the police to escort him. And that does cause some trauma, but I have to think about it this way. Like, I want to keep this patient safe. And sometimes to do that, we have to do things patients don't like. So here we call it emergency petition in Maryland. And that is what I would do. And the police officers would come. I would fill out the paperwork. The police officers would come, take him to the emergency department, and there the emergency room physician would evaluate him. And if he found that he needed to be admitted inpatient, they would admit him right there. He would most likely be on involuntary admitted, but it depends. If he says yes, I want to be admitted, they would do it voluntarily, but he would still be required to stay there for 48 hours in Maryland. And also, I just want to note that I was looking up if Celexa could have caused an increase in suicidal thoughts. And I found a recent study that made it very clear that Celexa is actually known for decreasing suicidal thoughts. And there was only one patient on Celexa in the study that had a completed suicide or suicide attempt in the large group. So it is a really great drug and pretty much does not have an increase in suicidal thoughts. So for my next patient, she's the 19-year-old mom that recently had a baby and is present with her husband. She's been dressing provocatively, having thoughts about an alien, and also thoughts about harming her child. I believe that she is suffering from postpartum psychosis. So postpartum psychosis can show up to 6 weeks after delivery of her child. And in this, she's at, I'm assuming week 8 if she's got a 2-month-old, and the husband says that she has been acting like this for a couple weeks. So my guess is that she's right within that time frame. And postpartum psychosis is usually shows up through like hallucinations and delusions, which she's having both of those, mood changes, which she is having, depersonalization, which she is also admitting to, disorganized thinking, insomnia, irritable, and thoughts of harming others, which is shown in the thoughts of harming her daughter. It is very common in first-time moms. They're not sure if it's because 45% of women that have postpartum psychosis do not go on to have more children, or if it's just, what happens. So usually with these patients, they are not aware that these thoughts are not connected with reality, which if you listen to the scenario, it doesn't really sound like she's aware that there's anything wrong with her way of thinking. Because of that, because they're unaware of like the issues, they usually need to be admitted to an inpatient involuntarily. And this is a medical emergency. It's important to realize in recent years, we've had issues of postpartum psychosis. Andrea Yates, and most recently, Lindsay Clancy. Those are two issues, two postpartum psychosis issues where the children ended up dying. So it's really important that we treat this. And I think the Lindsay Clancy case, where the mother killed her 3 children, and jumped out the window while her husband was going to Chinese, is kind of a reason as providers we need to realize that family members can't always protect their loved ones. And sometimes they don't know what their loved one is thinking. So it's important that we as providers protect the patients and their children and others. So, and the thing about postpartum psychosis is there's really no screening tool that we have. So a lot of things have to be done by just evaluating the patient and assessing them and doing a thorough assessment. And it goes off of what you as a provider think. So, and another thing to mention is that there is an increased rate in suicide and infanticide in postpartum psychosis. So this is a really, really important issue that if you are suspecting it, you need to follow through with it and make sure that everybody is safe. So most of these patients will go to the ER involuntarily. In my area, that's what would happen is I would have her emergency petitioned and go to the emergency room involuntarily, I'm assuming. Her husband is present. I would have the husband take the baby and we would have her transported via the police department, which is how we usually do it where I am, to the hospital, to the emergency room to be psychiatric evaluated. My guess is that she would have to be involuntarily admitted to the inpatient psychiatric unit. With postpartum psychosis, it is always important to err on the side of caution. And I can't reiterate that enough. The Lindsay Clancy case was heartbreaking to me. And it feels like there was a lot of things that could have been done differently. So we always just need to err on the side of caution. Another thing that I want to mention that we need to assess the patient for bipolar because bipolar patients are more likely to have postpartum psychosis. But a third of patients that have postpartum psychosis will actually not have any psychiatric diagnosis. And there is also, we need to question about family history of bipolar disorder because maybe the patient has not been diagnosed yet. But yeah, so both the patients would most likely need to be admitted involuntarily. I'm guessing the second patient would definitely be involuntary. The first one, it would be dependent on whether or not he was willing to go into the inpatient unit. And if he was not, it would have to be involuntary. Okay, thank you.